Hello everyone. In this part, let's study something about nephrotic syndrome. The nephrotic syndrome is defined by proteinuria of more than 3.5 grams per day, accompanied by hypoalbuminemia, edema, and hyperlipidemia. In practice, many clinicians refer to nephrotic range proteinuria regardless of whether patients have the other manifestations of the full syndrome, because these are a consequence of the proteinuria. The nephrotic syndrome may be primary and idiopathic, or it may be caused by a known underlying condition, such as diabetes, amyloidosis, or systemic lupus erythematosus. Although minimal change disease is the most common cause of nephrotic syndrome in children, idiopathic membranous nephropathy and focal segmental glomerular sclerosis are the most common causes in adults. The causes of idiopathic nephrotic syndrome in adults include minimal change disease, focal segmental glomerular sclerosis, membranous nephropathy, membranous proliferative glomerulonephritis, and other proliferative and sclerosing glomerulonephritis. Hypoalbuminemia, which is largely a consequence of urinary protein loss, also may be due to proximal tubular catabolism of filtered albumin. The redistribution of albumin within the body and reduced hepatic synthesis of albumin. As a result, the relationship among urinary protein loss, the level of the serum albumin, and other secondary consequences of heavy albuminuria is inexact. The salt of volume retention may occur through at least two different major mechanisms. One is the primary salt retention in the distal nephron. The other is that hypoalbuminemia reduces the oncotic pressure of plasma. The resulting intravascular volume depletion leads to activation of the RAS axis, and this activation increases the retention of renal sodium and fluid. Patients may present with weight gain, peripheral edema, and periorbital edema. Hypertension is common, and varying degrees of hematuria may be present. Proteinuria is more than 3.5 grams per day. Nephrotic patients often have a hypercoagulable state. Patients have increased risk for atherosclerotic complications and have elevated levels of total and low-density lipoprotein. Initial elevation includes laboratory tests to define whether the patient has primary idiopathic nephrotic syndrome or a secondary cause related to a systemic disease, toxin, or medication. Common screening tests include the fasting blood sugar and the glycosylated hemoglobin test for diabetes, anti-nuclear antibody test for collagen vascular disease, and a serum complement level, which screens for many immune complex-mediated diseases. After exclusion of secondary causes, a renal biopsy is often required. Biopsies are likely to provide a specific diagnosis, determine prognosis, and guide therapy. Treatment varies by the specific cause. Elevated lipid levels should be treated. Anticoagulation is needed if any thrombotic complications occur. Edema is treated with a low-salt diet and diuretics. The combination of loop diuretics plus albumin may be more effective than a loop diuretic alone for some patients who have refractory edema and the evidence of intravascular volume depletion. Corticosteroids and immunosuppressants are often used in childhood onset relapsing or steroid-dependent nephrotic syndrome. Rituximab 375 mg per square millimeter once weekly for 5 weeks can provide a median relapse-free interval of about 9 months. Okay, that's all. Thanks.